Hello everyone, and welcome to QuickMed, where medicine is explained quickly and easily. Today we will be discussing Cushing syndrome, how to evaluate and diagnose this disease, so let's get to it. Alright, before we can get started, we need to understand the hypothalamic pituitary adrenal axis and the negative feedback that's involved. Your hypothalamus is responsible for producing and secreting CRH, which is corticotropin-releasing hormone. CRH then stimulates the anterior pituitary to produce ACTH, which is your adrenal corticotropic hormone. ACTH then stimulates the adrenal cortex to produce cortisol, and it is excess cortisol that is causing Cushing syndrome. This excess cortisol also has a negative feedback on both the anterior pituitary and the hypothalamus in order to keep this entire system in check, so make sure to keep this in mind as we proceed. And then when we're at the level of the adrenal gland, as you probably remember, there are 3 layers within the adrenal cortex, and it is your second layer, the zona fasciculata, that produces your cortisol. Further inwards, you have the adrenal medulla, which produces your epinephrine and your norepinephrine. Let's now go over the causes of Cushing syndrome because there are quite a few. One of the most common causes is actually iatrogenic in nature, and this is due to the overprescription of steroids like prednisone. Another cause is Cushing disease, and when we say Cushing disease specifically, we're referring to ACTH-secreting tumors that are found in the pituitary gland. Cushing syndrome is just the umbrella term that encompasses all of these causes, but Cushing disease is specific for the pituitary. A third cause is an adrenal tumor. Either adrenal adenoma or carcinoma, and even hyperplasia can cause this. And then finally, you can have your ectopic ACTH-secreting tumors, and this is typically due to small cell carcinoma of the lung, and this is usually pretty high yield, so I would remember this for boards. So let's start with the clinical manifestations of Cushing syndrome, and we will start with the reproductive system. So commonly, patients will present with menstrual irregularities, and this can present as oligomenorrhea or amenorrhea. Patients can also present with adrenal androgen excess in the form of hirsutism or oily skin, and this is typically seen with adrenal tumors, specifically your adrenal carcinomas, because it's thought that these adrenal tumors are producing a lot of androgenic precursors. Let's now move on to the skin and musculoskeletal system. So the most common symptom that patients will actually present with is this progressive central obesity. They'll also develop this purple striae that you can see in the picture, which is a result of the enlarging abdomen. Along with the purple striae, patients will also present with easy bruising, and this is thought to be as a result of the loss of subcutaneous connective tissue due to the catabolic effects of cortisol. Patients will also have muscle wasting, and this is usually proximal muscle wasting and weakness, and this is again due to the catabolic effects of cortisol acting on the skeletal muscle. Let's now talk about some of the metabolic abnormalities that you find with Cushing syndrome. As a result of the excess cortisol, patients will have glucose intolerance, and this is because cortisol stimulates gluconeogenesis, and then you also have peripheral insulin resistance caused by obesity. Patients can also have hypokalemia on labs, and this is because cortisol can actually exert mineralocorticoid effects, so aldosterone-like effects, and lead to this potassium wasting. And then finally, patients can also present with neuropsychiatric symptoms in the form of insomnia, memory loss, and most commonly depression, which occurs in a majority of patients, more than 80% of them actually. And this depression is usually atypical in presentation, where patients will have more weight gain and an increased appetite, which is unlike what you usually see with typical depression. All right, let's now talk about the diagnosis of Cushing syndrome, which can be a little bit complicated, but we'll try to simplify things here. The main thing we're trying to understand is what is the underlying cause of this excess cortisol? Are we dealing with a pituitary ACTH secreting tumor? Are we dealing with an adrenal tumor or adrenal hyperplasia? Or is this an ectopic ACTH producing tumor? So the first step in diagnosis is to screen for hypercortisolism, or basically confirm that there is excess cortisol that we're dealing with here. And we can do this in one of 3 ways. We can get a late night salivary cortisol. And we get the cortisol late at night because cortisol peaks in the morning and then it goes down as the day goes on. And so when you're trying to rule out an excess production of any type of hormone, you want to check when that level is supposed to be at its lowest. We can also do a 24 urinary free cortisol, but that's a little bit more demanding on the patient because it requires them to collect their urine over a period of 24 hours. And then we can also do an overnight 1 milligram dexamethasone suppression test. And this is where you give a patient a small dose of dexamethasone, which is a type of steroid, to see if that induces a negative feedback and leads to a decrease in serum cortisol, which would be expected. If not, then you can confirm that there is excess cortisol in the system. So if there's a positive result on any of those screening tests, we've confirmed that there's excess cortisol, but now we need to answer the question of where is this excess cortisol coming from? Is it ACTH-dependent or is this ACTH-independent? And the way we do this is by checking an ACTH level. If that ACTH level is low, then we're more likely to suspect an adrenal origin for that excess cortisol. So either an adrenal tumor or adrenal hyperplasia, and then you can follow up with a CT scan of the abdomen to further characterize what's going on. Now, if the ACTH level is high, this tells us that this is an ACTH-dependent form of Cushing syndrome. But as we've already discussed, that ACTH can be as a result of a pituitary tumor or it can be an ectopic tumor. So now we need to differentiate between these two causes. So the way we do this is by administering a high-dose dexamethasone suppression test, usually in the form of 8 milligrams, and this is different than that 1 milligram screening test that we talked about earlier. And the reason we do this is because at high doses of a steroid, a pituitary tumor should still be responsive to that negative feedback, and so it should lead to a decrease in those serum cortisol levels when we recheck them after the test. On the other hand, an ectopic tumor is going to be completely resistant to that negative feedback because it's not involved in that axis at all, and so it would not affect the results of a serum cortisol level there. And so if after administering a high-dose dexamethasone suppression test, you get adequate suppression, that indicates that there's a tumor that's responding to that high dose, and it's most likely going to be a pituitary tumor. And this is important to know because it changes management and next steps. So if you're concerned about a pituitary tumor, you're going to get brain imaging, most likely in the form of an MRI. But if you're more concerned about an ectopic tumor, then you need to do imaging elsewhere in order to figure out where this tumor is actually located. Usually in the lungs, but it can also be located in other places in the body. All right, so let's now go over a practice question to see how Cushing syndrome will most likely present on a board question. So we have a 16-year-old girl presenting to clinic because of increasing facial hair growth over the last 5 months. The patient has gained about 15 pounds during this period of time. Her period began at the age of 11 years. Menses in the past occurred at regular 28-day intervals, but now occur at 45-day intervals. She also notes she has a low mood over the past few months. The patient is not taking any medications, has no allergies, and the rest of her medical history is non-contributory. An abdominal exam reveals striae over the abdominal region. What is the most likely diagnosis? All right, so let's look at some of the key factors in this question that would help you consider Cushing syndrome or lead you to that answer choice. So she's presenting with hirsutism, with the increasing facial hair growth. She's gained about 15 pounds, so remember that progressive obesity that we sort of discussed. And then she's having some menstrual changes where her menses were regular but now are becoming irregular. And then along with that, we have mention actually of low mood, so most likely depressive-like symptoms that she's presenting with. And then on top of that, on exam, we even have striae that are mentioned, and this is supposed to help us consider Cushing syndrome overall. So look out for these features on the question choice, and hopefully you should be able to get these correct. And I hope you guys all found this helpful. If so, please make sure to like and subscribe. And as always, good luck studying, everyone.